Knee dislocation. It's mostly a high energy trauma, direct anterior blow through tibia, and a posterior tibial translation, likely to have a PCL injury, popliteal artery contusion, and arterial intimal tear. These are mostly weather dashboard injuries. The low energy trauma, patient with morbid obesity with low energy fall, and can cause popliteal artery tear. History is formidable importance. Physical examination, look for the area of abrasion, tenderness, lower extremity swelling, knee effusion, knee instability or asymmetrical laxity. In 50 to 80% of the knee dislocation, it reduced spontaneously at the scene. So it's very important to have a look into these things: swelling, effusion, tenderness, instability. Suspect a dislocation if the radiograph depicts asymmetrical joint lines. Suspect a dislocation when there is avulsion bony injuries. Associated injuries: vascular injury 5 to 15%, neurological injuries 20 to 40%, soft tissue injury 15 to 35%, and bone injury 16%. Initial priorities: number 1, vascular status of the limb; number 2, neurological status of the limb; number 3, rule out compartmental syndrome. After knee is reduced, if there is normal pulse and perfusion is normal, it needs a rigorous follow-up. And if pulse is questionable, needs arteriography. If abnormal pulse but good perfusion, needs arteriography. If abnormal pulse and bad perfusion, it needs surgical exploration. Ankle brachial index is of quite significance. Ankle brachial index is Doppler systolic arterial pressure in the injured limb divided by the Doppler systolic arterial pressure in the uninjured limb. Ankle brachial index of less than 0.9 indicate of CT angiography. How to do ankle brachial index? The patient is placed supine. Evaluate the pulse by palpation. Pulse may be considered normal, diminished, or absent. Next, a blood pressure cuff is placed proximal to the ankle joint of the injured limb. The systolic blood pressure is determined by a Doppler probe at posterior tibial artery or dorsalis pedis artery. The same is measured and performed in the ipsilateral uninjured limb. Measure the systolic pressure at the upper extremity at the brachial artery. Then the ankle brachial index is obtained by dividing the pressure on the uninjured lower limb by pressure in the uninjured ipsilateral upper limb. So simple algorithm is, if knee dislocation is there, reduce the knee and obtain the pulses and obtain ankle brachial plex index. If the distal pulsations are present and ABI is more than 0.9, admit the patient for 24 hours for serial observation and examination. If distal pulses are asymmetrical or distal pulses present but ABI is less than 0.9, arteriogram should be advised. If there is absent distal pulse or clear signs of ischemia, emergent surgical on-table arteriogram is advised. Important is that the intimal tear of the popliteal artery may initially not be flow limited. In this case, any high altered ABI, consider CT angiogram. If not limiting flow, intimal tear is confirmed by CT angiography. Observe the patient closely. Keep the vascular team informed. Do not use tourniquet at the time of any reconstructive surgery. At admission, in case of absent pulsation, perfusion, emergent surgical exploration. Regarding the vascular injury after knee dislocation, if surgery is done within 8 hours, 11% chance of knee disarticulation. If surgery is done after 8 hours, 86% chance of knee disarticulation. Incidence of nerve injury is 4 to 40%. Sadly, 50% do not recover. Always surgical explore and neurolysis when you are doing a posterolateral corner reconstruction for these patients. If the peroneal nerve injury is on examination partial nerve palsy, observe and consider later on tender transfer. Or it can be explored when meniscoligamentous repair is done. For a complete nerve palsy, do electromyography. If there is no more traction potential, ultrasound to test the nerve continuity. If the nerve is in discontinuity or time from injury to possible surgery is less than 3 months, a direct nerve repair is advisable. Cases that should be taken to OR immediately. Number 1, irreducible knee dislocation. Number 2, open knee dislocation. Number 3, associated vascular injury with no perfusion of the limb. Number 4, compartmental syndrome. A dimple sign is a skin depression on the medial side of the knee. This is a typical case of rotatory instability. A medial femoral condyle is buttonholed through the medial capsule and the medial collateral ligament protrude into the knee joint. This requires open reduction. Open knee dislocation required also theater as soon as possible. Immediate neurovascular assessment before and after reduction. Urgent surgical management of open fractures, irrigation debridement, provisional stabilization with span and external fixator, and obtain MRIs and radiographs. As regarding associated vascular injury, knee should be reduced first. Knee should be spanned with the external fixator. Fasciotomy should be done depending on time of ischemia and characteristic of soft tissue injury. For compartment syndrome, the knee should be reduced first. The provisional spanning external fixator should secure the reduction. In fasciotomy, all the 4 compartments of legs should be released. Regarding the knee dislocation classification, either it is timing, which is less than 3 weeks, or chronic, more than 3 weeks. There is a Kennedy classification, that is anterior dislocation, or a posterior dislocation, or a medial lateral dislocation, or a rotatory, or combination. If at anterior knee dislocation hyperextension is more than 5 degrees, consider popliteal artery is disrupted. In a posterior knee dislocation, arterial injury is possibly due to intimal tear. Extensor mechanism can be disrupted. The Schenck classification is also important in decision making. KD1 is either ACL or PCL are intact. KD2 only ACL or PCL are torn. KD1 either ACL or PCL are intact. KD2 only ACL and PCL are torn. KD3 ACL, PCL and posterolateral corner is torn, or posteromedial corner is torn, that is KD3L posterolateral, KD3M posteromedial. KD4 ACL, PCL, posteromedial corner, posterolateral corner, all 4 are involved. KD5 is associated with articular knee fracture and dislocations. Regarding the decision making, reduce the joint first. Complete neurovascular evaluation, evaluate soft tissues, attention, and for the dimple sign, ankle brachial praxis index, knee radiographs, rule out emergent need for surgical trip to the OR. Regarding the close reduction of knee dislocation, gentle manual traction, avoid pressure over the popliteal fossa, Careful anterior translation of the bone located posteriorly. Make sure document the presence of pulses before and after reduction. After close reduction, keep it reduced. A brace may be difficult if there is high BMI. A spanning external fixator should be considered if the knee may not stay stable with the brace. A patient with knee dislocation and arterial injury. The three questions should be: is there an inability to maintain reduction? Then an external fixation should be applied. Is knee brace or splint possible? Then external fixation should be advised. If inability to mobilize with a brace, external fixation should be advised, and reconstructive surgery should be implemented. Before definitive ligamentary reconstruction, a DVT prophylaxis should be administered during the entire interval between the spanning X-fix and definitive reconstructive surgery. In case there is documented DVT, advice for inferior IVC filter placement with anticoagulation. Regarding the ligaments repair versus reconstruction, acute repairs are advised for capsular peel-off injuries. The corner injuries should be reinforced with reconstruction. Regarding the posterolateral corner, a repair will fail in 37% chance. A reconstruction has 9% chance of failure. Any avulsion of large bone fragments from the fibula needs a ORIF with a screw and a washer. Regarding the posterolateral corner injuries, the important structures are three. Number one is fibular collateral ligament attached to the fibula from the proximal femur, distal femur. Popliteofibular ligament. Number three, popliteus tendon. It is important and critical to determine where you anchor the reconstruction in the femur to avoid change in graft length or flexion extension. An important point for the femur is intersection between Blumensaat line and a projection on the posterior femoral cortex. The line is drawn and the mark is the area where reconstruction should be placed. There is a modified two-tailor technique. Graft passes through fibula up to the isometric point with a suspensory fixation. A separate popliteus graft is also utilized if needed. Tighten FCL graft in 20 to 30 degree of flexion and neutral interrotation. Tighten popliteus in extension. And then reconstruct the posterior lateral corner structures. In the biomechanical study, double PCL reconstruction more closely replicate the XYO biomechanical functions of native knee. A hinge external fixator can be utilized for very unstable knees. A hinge knee brace is not better than a hinge external fixator, and there are higher failure rates with hinge knee brace. Regarding acute or stage repair. Acute repair is one which is done in the first 3 weeks of the injury when tissues are still identified without significant scarring. A staged repair is a repair considered in repairing reconstruction of the peripheral ligament structures by delayed cruciate ligament reconstruction once the range of motion is restored. Delayed reconstruction means that the peripheral soft tissues have some degree of healing and the knee has complete range of motion. Clinical aspect to be considered is PCL determines the reference axis of rotation. So PCL reconstruction takes precedence over the ACL, as it is determine a reference alignment between the tibia and the femur. So most of the surgeons will prefer to do acute reconstruction of posterolateral corner as well as PCL, and then delayed reconstruction of ACL and other structures. A Schatzker type 4 fracture should be considered as a knee dislocation. The fracture should be shown up with a widened tibial plateau and translation and lack of containment and instability. A periarticular clamps applied to the medial femoral epicondyle and to the anterolateral rim of the tibia to reduce the dislocation.